people, and 180,000 people had already died. And thankfully, there was another 706,000 who have recovered from the disease. In our country, Kenya, by yesterday, there were 303 cases. We have so far reported 14 deaths, and we are also fortunate to have 83 recoveries. Next slide, please. Now, I'm just taking us through this, but I'm sure the audience here are very familiar with all these conditions, that COVID-19 is caused by the coronavirus, referred to as SARS-CoV-2, is very highly infectious and also contagious. And the mode of transmission so far confirmed is that the droplets from the upper aerodigestive tract are the main mode of transmission, actively through cough and sneezing, and even speaking. And then there's passively because of the things we touch. All the time, everywhere that is contaminated, we end up touching mouth, eyes, and nose, not necessarily in order of that priority, but easy abbreviation has been said that MEN, for mouth, eyes, and nose. However, as increasingly the disease is being understood, initially there was a bit of controversy, but now it is clear that aerosols floating in the contaminated air are also a mode of transmission. Next. Now, health workers who are at the epicenter of this disease transmission, as I've said earlier, are the dental surgeons, because we work in the oral cavity, maxillofacial surgeons, because we work in the oral cavity and the neighborhood, the ENT surgeons who work in the nasal area and the pharynx,
Hello, we seem to have lost Dr. Walter Odhiambo. Let's give him 2 seconds to try and reconnect with us. Hello, Dr. Walter. Hello. Okay. We apologize for that. We seem to have some issues on Dr. Odhiambo's side. Hello. Hello. Okay. Hello, Dr.
Hello? Hello?
Hello, hello, Dr. Odhiambo. We can hear you now.
We lost connection.
Yes, apologies for that.
I don't know whether it was from my side or your side.
We also not sure, but we're glad to have you back.
All right, thank you. So as I was saying, dear colleagues, that the people at the epicenter of this pandemic are dental surgeons, maxillofacial surgeons, ENT surgeons, and anesthetists, especially when the condition becomes severe and intubation is required. Unfortunately, all these professional colleagues must work in close proximity with the patient and cannot keep the distance. There is also concern about ophthalmologists who must work very close to the patients, and as well, the conjunctival transmission is suspect or has been confirmed. So aerosols in the environment are generated during our procedures. And for example, dentists cannot resist. Most dental procedures require the drill, and most maxillofacial surgeons, so long as they are not operating on soft tissues, if they are operating on bony tissues, we have to cut and use drills to put plates, to put implants, and even to resect bone where necessary. But apart from just aerosols and the droplets that we must work in, we are also actually in danger of getting in touch with contaminated surfaces, because there's no way you will do procedures and the surfaces remain uncontaminated. And these are the real issues that we must look at. Apart from the risk, therefore, of spreading this disease to ourselves, she has moved to the next slide, we are at the risk not only of getting infection from the patients, but we are also possibly a vector of the disease, of transmitting it to the patients, but even most painfully to the family, as you will see in the subsequent slides. Next. Yeah, this slide you see, I got from one of the presentations of a paper published by those who had experience in Wuhan, where the COVID was first reported in December, mid-December last year. And you can see, if you look at the screen, you will be able to see that these were people working in this. They designated the buildings where all these people were working, building 1, 2, or 3. But what I wanted you to appreciate here is that number of persons on the same floor or on that department, are there any close contacts infected? And just look at that. You can see that close contacts infected were family members. If you look at that from January, this is what happened in Wuhan, and this is the true story. So these were the dentists in various disciplines, preventive dentistry, prosthodontist, there's some library there in the dental school, oncology, and teaching office, and all that. These were the buildings where they were working. Somebody did birth research and followed who they got contact with, but look at who got infected. Are there any close contacts infected? And you can see that the close contacts were infected, most likely were family members. Very critical to this presentation. Next slide. Next, please. Yeah, what happened in Wuhan, which is also critical to the presentation we are having, is that during the outbreak in December, the events happened as follows. These graphs here, bar graphs, indicate the private practice, number of outpatients seen in private practice for dental clinics. And at this point, Hubei province activated level 1 response to public health emergencies only. And here, Hubei, this final arrow here is the government released regulations on dental services during the outbreak. Initially, this was the outbreak progression, but at this point, as the disease progressed, at this point, you can see the dental practices, outpatient practices went to almost zero as the disease, as the pandemic, number of cases involved in the pandemic rose exponentially. So this slide I've just shown to kind of inform what response we should think of in our setup. Next. Another important report that I found in literature was from Dental Tribune, which indicated that in Indonesia at the time of this report, which was 16th of April, they had reported about 5,000 cases and about 10% deaths, which is about 500 as well. In this report, there were 24 medical professionals who who had died of the condition. Out of the 24, 6 of them were dentists. That's making 25% of the fatalities linked to COVID-19 from the medical professionals. Now, this is very important because not all these dentists who actually died of COVID were on the front line. But what is of note is that Indonesia Dental Association did not advise closure of the dental clinics. Most of the countries, as we speak, immediately, China, India, Canada, Italy, USA, UK, their national association actually advised closure of private practice. Now, if you look at this, well, what is also important is that the Kenya Dental Association advised closure in the second week of the case, the first case that was reported in Kenya. And they recommended suspension of elective procedures. And this was also what was the position of the Association of Oral and Maxillofacial Surgeons of Kenya. Next. This, I included this slide to show you, the definition of emergency as was described by the Kenya Dental Association and the Ministry of Health in their release, which was on 17th of April. And you can see that was the definition of emergencies that KDA, Kenya Dental Association, and the Ministry of Health Dental Division advised that can be performed, and the rest of the procedures were to be suspended. That was a recommendation because they had no legal capacity to put it as a decree. Next. These are the conditions that the KDA listed as emergencies. One was uncontrolled bleeding in the mouth and the orofacial region, cellulitis or soft tissue infections intraorally or extraorally that potentially threatened the airway, and trauma involving the facial bones that potentially were likely, if not treated, to compromise the airway. In the initial release, they did not include dental pain, but subsequent review by the Kenya Dental Association included severe dental pain that was not amenable to pharmacotherapy. And here, pharmacotherapy refined as analgesics that could be given non-parenterally, if they could be given orally. Then there was also dental trauma resulting in avulsion of anterior permanent teeth. Avulsion of deciduous teeth was not included in this. Then KDA recognized, and MOH recognized, that patients with malignant disease conditions, probably that were rapidly progressing, could not be suspended, and therefore these cases were to be considered as emergencies or urgent. We can look at the next slide, which was from the UK, England. Next slide. This is from National Health Service in England, and this was their definition of urgent dental care: life-threatening emergencies due to potential airway compromise, which is similar to what the Kenya Dental Association and the Ministry of Health recommended; rapidly progressive orofacial swelling; trauma and dentoalveolar injuries from avulsed teeth. This is important because sometimes the teeth that were avulsed, if they were permanent, really it would be important to reimplant them, and you will see later on in some future slides how this recommendation was complied with. Persistent hemorrhage definitely would require that patients be considered emergency. Then they talked of dental conditions that have led to severe or would lead to severe systemic illnesses. So in cases where, for example, we had periodontitis or pulpitis or pericoronitis in a patient, in a diabetic patient, probably you would consider that as something that needs to be controlled and could not be suspended. Severe pain that is not responsive to remotely prescribed measures, we have talked about that. Fractured teeth with pulpal exposures. If the teeth was fractured and the pulp is not exposed, it probably does not fall in this category, as it's possible that they could still be suspended and not necessarily be considered as emergency. However, where the pulp was exposed, it was considered as emergency, as most likely the pain that is associated with exposed pulp could not be bearable to the patients. Then, of course, severe infections of the kind that, like Ludwig's angina, or any other infection that definitely will progress to a worse situation. Suspected malignancies, we have talked about that in the Kenya Dental Association. And orodental conditions that would worsen in systemic disease. They are conditions that would worsen the situation when the patient had a systemic disease, and then the orofacial condition would make it worse. So that was from the National Health Service of England, and that is their guidelines. Let's take next. What was recognized by the National Health Service is that urgent dental care could be primary, that is what we do as dentists or maxillofacial surgeons in the clinics, in patients who are coming to see us or who are making phone calls. But then there was secondary care for COVID patients in hospital. And that means patient who has been diagnosed with COVID-19 is admitted in the hospital, but they suffer any of the conditions that we have described above, then the dentist would then respond as secondary care personnel. What I wanted us to take note of is that guidelines do not at all take charge of your professional judgment. And all the guidelines presented here are not necessarily the 10 commandments that you must follow, but every healthcare professionals in the dental and maxillofacial discipline, just like in other disciplines, is required to exercise their clinical judgment. And there are several cases that might have not been mentioned in this presentation, but which in your own judgment can make you refer the patient for treatment or have the patient treatment. And as has been said, COVID-19 is a new disease, rapidly changing, and we still have a lot to understand. So we really expect that every clinician should actually make their own judgment and see what should be done to give the best or optimum care for the patients. Next. Now, as I progress, one of the key things that would influence the guidelines that we will give or supposed to be given by all our centers is staff safety. And number one, which has been prescribed by nearly in all aspects, is that stay at home. And it is also the key. Staff should stay at home or work remotely. And I will give the some of the guidelines on how to work remotely. The recommendation by most professional association has been that stop provision of routine non-emergency or urgent procedures. And this Kenya Dental Association, for example, recommended that we stop provision of non-emergency care. Association of Oral and Maxillofacial Surgeons of Kenya too has recommended that we suspend non-emergency care. The National Health Service of the UK suspended including non-urgent dental cases, including orthodontics. And You will know, for example, as we go on, that putting of things like brackets require a lot of spraying and drying of the surfaces, and that probably generates a lot of aerosols. As we progress in this approach, the public should be made aware through messages of lack of routine dental services, and also be told where to get emergency care. Remote consultation, which has been recommended, largely should include advice. The NHS have described them as AAA. Advice, analgesia, and antimicrobial. But antimicrobial, as you are aware, there is what we call stewardship that requires that antibiotics should not be given just because of any condition. And it is very important to remember that we do not need antibiotics for acute pulpitis unless we have evidence of infection. Acute pulpitis is one condition that we should not give antimicrobials for. However, analgesia is recommended. And so for this, we recommend that you give advice to the patient and give analgesia and possible antimicrobial if indicated. Next. Next slide, please. This is the guideline to remote consultation and triage, which every dental clinic and maxillofacial surgeons probably would think of. Number one is that we can make use of telephone or video. We do not have to get into physical contact with the patients. Face-to-face consultation should be limited and be given only when absolutely necessary. The first thing is about risk assessment questions. And I'll show you the risk. No, it's okay. Just I'll show the risk assessment questions. The 3A, which I've described, is where feasible, then the patients do not have to come to face with the doctors. Refer when absolutely necessary. And patients at risk should be advised on community safety protocols, including how to travel. Please, this is very important. If patients are coming to the centers for treatment, then they should not, if possible, avoid use of public means. And if they must, then they must have masks and all other protective measures to protect the community from exposure. Face-to-face consultation should be in centers with personal protective equipment. And if they are done, we should avoid aerosol generating procedures as much as possible. And that means we should do non-aerosol generating procedures mostly. Next. Yeah, this is the risk assessment questions that you should ask the patients on phone or on video call. I mean, this applies to all situations of COVID-19, not just in dentistry. And new cough that was not there before, temperatures that are above 37.8 degrees centigrade, any household member with a cough, COVID exposure, if there is history of that, if there is anybody under isolation or the very patient who is calling has been under isolation because of COVID. And then there are shielded patients. These are patients who have been identified as people who are at risk of developing severe disease in case they are exposed to COVID. And this includes such patients who are aged above the age of 60 years, and of course, with chronic conditions like hypertension and diabetic mellitus, among many others, who are at risk of developing severe disease. Such kind of patients should be noted and proper measures be put in place if they are making consultation. We must insist on minimizing escorts. So patients coming to these centers should not come escorted by a clan, as we normally see. Sometimes patients come with their entire clan. Families, minimize the people who are escorting the patient. If possible, they should come alone. If they need be, let them come with the same person from the same household to minimize exposure and exposing the clinical staff as well as the other patients that may be seen. Next. So what should be the recommendation for emergency centers? And this is coming as far as what has been previously recommended, is that we suspend routine practice in our clinical centers and we create emergency care centers. These emergency care centers do not have to be necessarily in our clinics, but a team of doctors in particular center can actually agree on where they would like to have their emergency center located. The University of Nairobi Dental School, for example, has been trying to get itself opened to act as one of these emergency centers. But so far, what has been recommended by the Ministry of Health is that the hospitals in the counties and the hospitals that are well equipped can act as these emergency centers. What are the requirements? One, trained and skilled and experienced staff. This is not time to have interns. This is no time to have inexperienced clinicians trying procedures. This is time to have trained and skilled staff so that the time taken to care for the patient is minimal and exposure is to the risk is reduced. The clinics or centers should be conveniently allocated to minimize travel. We don't want, you know, the government has banned travel out of certain centers for good reasons. And whatever the centers are, they should be areas which can be accessed by majority of the population without having to travel long distances. They should have convenient opening hours, not too short so that there's a stampede, but enough to allow for physical and temporal spacing. That means physical spacing so that the patients are spaced, and temporal spacing so that the time of visit is clearly separated. I mean, the hours of coming to the clinics are clearly defined and separated. These centers should be able to provide, or at least if the patients can have them, they should be able to provide masks. They should be able to provide hand washing facilities with soap at the entrance, and they should be able to have available sanitizers. It is recommended that the procedures to be done for emergencies be made short as possible to reduce chances of exposures. And it is strongly recommended that these procedures be non-aerosol generating procedures. Aerosol generating procedures should be only done when absolutely necessary. If we do non-aerosol generating procedures, we will need level 2 personal protective equipment. If we do aerosol generating procedures, we will need level 3 personal protective equipment. And level 3 will include the coverall or hazmat suits that you have seen that covers totally. So we would, in what guideline we are saying here is that avoid procedures as much as possible, use remote consultations and AAA as a mode of management. If patients must come face-to-face for consultation, they must all take all the safety measures. If they are then to be treated, non-aerosol generating procedures are recommended. Setting should be with adequate space and ventilation, and staff and clinicians' indemnity for these procedures is something that must be taken into account, because any staff member who is exposed, as I said earlier, puts their family members at risk and the community. And this is one area where we have to be very cautious, because we must see and put in place indemnity procedures, including where to isolate staff or quarantine staff who are suspected to have been exposed. And that should be a place where there is also dignity and some respect, not as we have seen where quarantine has become kind of an extended prisons. Next. Care center continues. If for the care centers that are offering this emergency care that we have talked about, they should have a clear 2 meters separation in reception rooms, and possibly there should be labels to indicate that this is where you sit, this is where the next person is sitting. 2 meters separation, and should be labeled if possible. Remove all non-essential items from the waiting room. Our waiting rooms previously have been very nice. They have magazines, they have toys for children. Unfortunately, these times call that non-essential items be removed from the waiting room, just to reduce any possible risk of spread of infection. They should be clean and well aerated. And for dentists and maxillofacial surgeons, fortunately, we had always observed standard infection control procedures. All dentists know how to wear masks, or most dentists know how to wear goggles and protective goggles, even to the patients. And all of us, dentists and maxillofacial surgeons, already have been using screens. A number of us were using gowns, disposable, but this now becomes critical. And for the clinics that will be running, standard infection control precautions have to be marked. In addition to that, there's transmission-based precautions. And we have talked about transmissions possibly being through contact, being through droplets, and aerosols. Next, please. Unfortunately, one area where dental practice and maxillofacial practice has now to be more vigilant is airborne transmission. And the aerosols have been confirmed that the COVID-19 can be transmitted through aerosols, and they are very tiny, and our traditional surgical masks now cannot guarantee you protection. So much as all the precautions of contact are there, precautions of hand hygiene, precautions of respiratory discipline, cough and sneezing, precautions on which are more important to the dentist now must include training on how to put on the personal protective equipments. And personal protective equipments does not simply refer to the hazmat suits and coveralls, but also the gowns and the masks. Thanks. So this is a very important slide, and I want us to look at it carefully for all of you who would like to continue practicing. Number one is that training on donning and doffing of personal protective equipment. So we have to start with training our staff and ourselves on how to put on and how to remove personal protective equipment with minimal contamination. And again, personal protective equipment does not only refer to the suits, it refers right from the masks we wear, the gloves, and all other accessories that we wear to protect ourselves. Know what PPE to wear for each setting and context. Again, we have said there's aerosol generating procedures, non-aerosol generating procedures. There's higher risk in some areas, there's lesser risk in some areas. We must know what PPE to wear and in what context. Then access to PPE that protects them from appropriate setting, inappropriate setting. So it might not be the clinicians themselves, but whoever the employer or anything, the access to PPEs must be guaranteed. Gloves and aprons are subject to single use. This is definitely known to all of us. Standard infection control procedures requires that we dispose gloves, we dispose aprons, but there are others that may not be for single use. Like fluid repellent surgical mask and eye protection can be used. You can use them for a whole session of work rather than single patient or resident contact. So these are provisions where you can actually reuse something if they are appropriate. But again, you must be conversant with the guidelines given by the manufacturers. Gowns on coveralls can be worn for a session. That means you can be having a session where you are seeing patients from morning to 1 o'clock, and you can wear the same gowns and or coveralls to see the session. Hand hygiene should be practiced. This one we can't emphasize, and I'm sure everybody already knows. And staff should take regular breaks and rests. It is obvious that any staff member who is put towards too much strain and working for long hours will eventually lose guard. They will no longer be able to be cautious, and eventually you end up with contamination. If staff members are not given a break or rest, eventually fatigue makes them a bit careless, and not only are they exposed, but they also expose the colleagues and other patients. Next slide, please. The N95 mask has been talked about a lot. I don't want to say much about it. It is why it is more superior to the surgical mask is that it gets a good fit and blocks any leakage from the sides. So this mask, if for dental procedures and maxillofacial procedures that are aerosol generating, one should always wear masks that are filtering and do not allow leakages from the side. They must be fit checked if you have to wear them, and they must be seal checked to confirm that they have no leakages. And this is important for training of the staff who will be working in these areas. Next. These gowns we have seen the highest level of protection that the staff members who are in contact, who are likely to be in contact with the COVID positive patients should have. And these gowns are generally not very comfortable, so people have to wear them for a short time. The future of dental practice is such that we may not have to go this far, but I think it is important for us to note that whatever gowns we will be using for protection should be such that they guarantee that we are protected, and most of them should be waterproof. And if you have to wear gowns that are likely to be to leak, then you are supposed to wear a plastic apron inside. And I think surgeons are aware of this. Most surgeons, when they are going to operate on patients where they expect a bit of bleeding or a lot of fluid contact, usually put a plastic apron inside to protect. If we made this for single use, you know, for example, in dentistry, then the treatment will never be affordable to any patient. So we have to think and see how best we can protect ourselves and protect the patient and still keep the cost within affordable range. Next. So this is the prescription for your personal protective equipment. We start with non-AGP, non-aerosol generating procedures. Aim to prevent contact or droplet transmission. Get eye protection, disposable fluid resistant surgical masks, and disposable apron. We have been used to intraoral radiographs, and now, again, at this point in time, the advice is let's try to use to avoid intraoral radiographs, where possible use OPG and maybe CBCT if necessary. The issue of intraoral radiograph is that they're most likely to expose you to droplets. Aerosol generating procedures, I have already stated that the general consensus is that avoid them as much as you can at this point in time. To prevent aerosol transmission, disposable fluid repellent surgical gowns, long sleeve, waterproof protective apron, gloves, eye protection, and filtering face-piece respirators, just like the N95 masks. For endodontics and restorative procedures, the use of high-speed suction and rubber dam is highly recommended to reduce the aerosols. Next. And what are the aerosol generating procedures in dentistry that we must routinely do? And I'm really afraid I don't know how dentistry can survive without these procedures, because these are the procedures of routine dentistry. The use of handpieces and ultrasonic scalers, especially high-speed drills in restorative procedures. And you know, we mostly like the routine fillings, crown and bridge work, and endodontics will require high-speed drills. Surgeons in maxillofacial surgery, we need high-speed drills. We need saws to cut the bone. However, it is recommended that where we have to remove the bone, maybe this time around, we contend with slow speed with some slow water irrigation. 3-in-1 syringes, I don't know how restorative dentistry can manage without 3-in-1 syringes, but it is one of the areas of aerosol disposal. 3-in-1 syringes is required for drying surfaces in composites. It is required for bonding in orthodontics. And for now, really, one has to be extremely careful if they have to use 3-in-1 syringes. Actually, avoid using 3-in-1 syringes if you can. And other compressor-powered equipment, because these are the areas from which aerosols are generated. Next slide, please. Here, this slide is very compact, and I don't know how I can remove these pictures from here. Let me see. Yeah. This slide is compact, and I thank my residents, especially Dr. Bati, for these pictures, which is to highlight to this, in this presentation, what are some of the emergency conditions that I've mentioned. And here is trauma of a gentleman who was in a motorbike accident. And really, we must do something about this. So this is the kind of emergency that has to be attended to. And you can see the multiple fractures that these patients sustained. The mandible is fractured, the frontal bone is fractured, and we have infraorbital, zygomatico-orbital fractures, and even nasoethmoidal fractures. So pan-facial fracture. This patient obviously requires some attention and cannot be suspended, even if we are in the era of COVID. I talked about avulsion of teeth in this young lady. You can see she lost 2 teeth. Fortunately, these 2 teeth were not broken, they were available. And somebody who was fairly informed knew that they can be carried in milk, and they carried the 2 teeth to the hospital, and the teeth were then splintered back in position. Again, this is really one situation where we cannot say that since we have COVID-19, we should do nothing about this. So this is a good job, and the tooth was splintered, and we think that it will get back well. So this trauma, so you can see these are cases of trauma that we indicate are emergency or urgent and should be attended to even in this era of COVID. Then we have neoplastic lesions like these ones that potentially can endanger the airway. You can see this pyogenic granuloma, or can even be a neoplastic oral squamous cell carcinoma, or any other neoplastic lesion. What is key here is that this patient has an endangered airway. And so intervention should not wait, because the patient would probably lose their lives. This elderly person with, again, a carcinoma that probably was advanced, but the main issue here is that he was not able to feed, and again, the airway is under threat, and this patient then has to be taken care of because we really cannot put them on the waiting list. So these are examples of emergency cases that would be, should be, not be ignored. The next slide, please. Infections. This, if you look at this, this is a periapical area of 4-7, and it shows, and then the patient presents with this. And again, this is the kind of patient we cannot put to wait and should be attended to. So incisional drainage and management of this, either by extraction or whichever other method, is constituted so that the patient can be safe, because really these are the situations where we know can get worse, and that is not something you would wish. And so this is either urgent case which is considered urgent because it can then progress to emergency. Again, an infection in this parotid region, you can see they have been to drain so that the patient can get well. The problem with this kind of infection is that they can either get systemic or they can spread in the locoregional cervical region and cause obstruction of the airway and then loss of life. Next slide. And finally, this patient who suffered a fatal post-tooth extraction hemorrhage, again, these are the kind of patients whom we must be very, very much alert and think of not letting them be on the waiting for too long. They have to be attended to. Either in this patient, the airway needed to be protected, and whatever the cause of hemorrhage to be addressed so that the patient can be, the life can be saved. So these kind of situations, even if we are in the era of the grappling with the crisis of the COVID pandemic, requires that we attend to them so that we can save lives. And I think it's important for all of us to remember that the other diseases have not taken a break. And even as we try to control the spread of the COVID-19, we should be able to attend to other patients' needs. Next slide. Okay, I had another slide which I think I did not send, but this is just a slide for the dental school and the Kenyatta National Hospital. But there is a slide which probably is missing here that I wanted to mention about, to discuss, and it's subject to debate among the colleagues here to comment on, is about the testing, the need for testing for the staff who are going to be in the front line of management of patients. Should the, is there a need to have these clinicians tested for COVID-19, and what should be the protocol, and what should be done if our doctors have to continue seeing patients? Should we, for example, insist that the doctors who are going to see patients must be tested for COVID-19, or what is the way forward? And again, what I would like us to comment about is whether patients we see in these emergencies, if they are not really emergencies, but urgent, emergencies are different, but urgent, should these patients now be subjected to COVID-19 tests? So I think with that, I would like to end this presentation, and I thank you for your attention, and now we can have questions and comments. Thank you.
Thank you so much, Dr. Odhiambo, for that comprehensive presentation. I can see Dr. Koech is online. Would you like to add an input, Dr. Koech? All right. As we wait for Dr. Koech to add an input, I'd like to go to the question and answer session. And yes.
Can you hear me now?
Yes, we can hear you.
Yeah, I was just saying good afternoon and thank you everybody for attending. Thank you, Dr. Odhiambo, for the good presentation. I think we'll straight away listen to the discussions so that we can move on, finish.
Okay, thank you so much for that. Dr. Odhiambo, there are a few questions that have come in. And the first one is from an anonymous attendee, and he's saying, how shall we do phone consultations and charge when this has not been the norm? Financially, private practice has taken a beating. So I've seen some of the your way forward is that they need to do remote consultations and only attend to emergencies only. So the dentists in the group are wondering, how do they go about this? How do they charge for that?
Maybe I can take up that one. We really don't have ways of charging for phone consultations. I think these are a unique situation where we just have to assist the patients. Yeah, I don't think that we'll be able to bill patients for phone consultations. I mean, they just asking them to buy analgesics and all. I don't know.
Okay.
I think this will have to be pro bono, in my opinion. But obviously, in the course of the phone consultations, you might get a situation that might require urgent treatment or emergency treatment. Then that means that the patient has to come to you for you to treat and use the appropriate guidelines. Yeah.
Okay, thank you for that feedback, Dr. Koech. My name, sorry, I didn't introduce myself. My name is Dr. Kalondu. I am a medical officer, and I wanted to ask just a clarification because I didn't understand what non-aerosol generating procedures are in dental practice. Because whenever I go for a dental visit, like almost everything will either generate splatter or an aerosol form. So what are these non-aerosol generating procedures that people can safely do in their clinics during this time? They're not emergency, but I can still, as a dentist, practice that in my clinic.
Yeah, well, really, there is, for routine work, there would be almost no procedure that would not generate aerosols, but there are those ones that probably would generate less. Let's say that you must do an extraction of a tooth, then you might consider that to have less aerosols. But when you have to start using a drill, then obviously there'll be aerosols that will be generated.
Okay. So there's a concern from Judy Kose, and Judy is saying, thanks to Dr. Walter, moving forward, when normal practice returns, how do you see the disease changing the dental practice generally with regards to mode of consultation, and seeing that we have ongoing community transmission for a long while? For how long, in simple terms, for how long are we asking the dentist to stay away from work? Apart from the emergency, just normal routine private practice work. And do we see this changing the way we've been doing business? I know we won't go back to as normal as we were. We'll have a new normal. But will this change how dental practice has been done in Kenya or in the world?
Is Dr. Odhiambo there?
I don't know, he's left. He's dropped off. Oh, you should get back on.
Has he dropped off?
Yes, he's dropped off, but he's rejoining right now.
Okay.
All right, and then the other question I wanted to ask, although it's not on the chat box, that was from Dr. Odhiambo's presentation. He talked about staff indemnity. I'm just curious to find out, has the Kenya Dental Association negotiated something maybe with a specific insurance company to offer the dentist some indemnity cover? Considering in public practice, nobody offers you that, you have to get it on your own, but is there a special package by the KDA, or it's just under KMA arrangement?
Has Dr. Odhiambo dropped off again or what?
You're trying to get him, Dr. Kinede is trying to get him to join back so that we...
But now probably to you, the facilitators, and probably you've listened to more presentations on this. What's the value of the testing of patients before treatment? Because I think going forward, that might be the immediate thing that we might need to do.
I'll give an example of what's happening in Kenyatta because that's where I'm based.
Yeah.
For the suspected cases, testing is being done. The results are taking about 6 to 12 hours to come out. We are now having a faster turnaround time compared to previously, although we hope it will get faster than that.
Yeah.
Yeah, so we still have a few labs that are doing it. We have the National Influenza Lab, Cambry. Now we have the United Lab, University of Nairobi also doing that. KNH-CCC Lab is also doing the testing. So if it's for an emergency procedure, not unless you advise your patient to do the test a few hours in advance before booking their appointment, that might be feasible. But that's for non-emergency, but for the emergency procedure, you might have to offer care first of all as we wait for the results. And that's what is happening right now at the accident and emergency and the pediatric emergency units. We're offering care first as we continue waiting for the results. But of course, we're bound in the PPE as we continue doing that.
Now, so my concern is about the accuracy or the sensitivity of these tests, because there are reports from elsewhere that nasal swabs generally have a 60% sensitivity, meaning that we still have about 40% false negative rates. Yeah. Is there anything on that? Anything new regarding the accuracy of the tests?
Tomorrow we'll be having a presentation on the lab, and those are some of the discussions that we're going to have. We're going to talk about testing tomorrow afternoon.
Okay.
And this will be Dr. Kinode, who is coming tomorrow afternoon. Professor Matilu Mwau is the one who will take us through that discussion. So we'll be able to address some of those issues, because we've had issues of testing. So those are some of the questions that he will be addressing. So we are glad to see Dr. Odhiambo is back.
Okay.
Yeah.
Sorry, internet decided to lock me, but fortunately when I just finished the presentation.
Ole, welcome back, Dr. Odhiambo.
Thank you.
Maybe I'll just go back to two questions or a concern from Judy Kose. I don't know if you'd seen it before, but Judy was saying, thank you, Dr. Walter, for the presentation. Moving forward, when normal practice returns, how do you see these diseases changing the dental practice generally? And mode of consultation, seeing that we will have ongoing community transmission for a long while?
Has he dropped off again or what?
I can see him still there. Oh, the internet too. Okay, his internet seems to be acting up. Okay. Hello, Dr. Diambo. All right, but there's a question from Mary, and Mary is asking, how do we handle orthodontic patients already on treatment? Will they not develop hypocalcification? And there's another question from Okay, there's a concern from Dr. Kituku Mumo. Sorry, Dr. Odhiambo's network still seems to be acting up.
Yeah.
Yeah, there's a concern from Kituku Mumo, Dr. Kituku Mumo, and he's saying dentists have been accused of missing from the front line in the fight against COVID-19. Can we clarify this position as misleading, since being in the front line in timely management of emerging dental emergencies is indeed participating in frontline work, as this minimizes the possible clog up of much needed COVID intervention capacity while preventing possible advanced disease. For example, that could possibly stretch an already stretched healthcare system. So his concern is that there's been accusation that dentists have taken a back line, but what he's saying is that they're actually in the front line, but they're trying to preserve the resources that are there. So they're limiting the amount of work that they're doing, but they're there, they're available. Somebody from Meru level 5 is asking, can they clarify the level 2 PPE to be used in routine dental patient examination? Dr. Dembo seems to have completely fallen off from us. Let me see, can you, Dr. Ireri is asking, can we comment on minimum PPE available and availability and affordability for dentistry in public and private practice? And what you think policymakers need to do? An anonymous attendee is also recommending that Kenya Dentist Association can develop a screening tool which clients fill in as they come in, and for suspected cases, they send the cases for COVID-19 testing. That's a recommendation from a participant. Elias Ragea, the fact that dentists are among the health professionals that are at high risk as much as COVID-19 pandemic concern, do you recommend massive test on health professionals, especially dentists, after COVID-19 crisis ceases and resumes normal duties? Thank you.
Has Dr. Odhiambo left completely?
It seems so, but Dr. Kennedy is still trying to get in touch with them.
Okay.
Yeah, he's still trying to get in touch with them.
Okay, I think what you can do is you can hear me.
All right, there's a comment.
You can answer the questions from the phone. Yes.
There's a comment from an anonymous attendee, and he's saying, excited to listen in on my senior colleagues. The Kenya Dental Association guidelines are clear on dental emergencies, owing to the fact that most routine dental procedures are aerosol generating procedures. My colleagues and I have had to close our practices for 5 weeks now. We are currently employing AAA approach, which we'll do for now. From Dr. Musera is encouraging the colleagues. He's saying, thank you for the presentation, Dr. Odhiambo. Kindly repeat the PPE 2 and 3 protocols. Secondly, my humble appeal to my colleagues is to adhere to the MOH KDA guidelines. The sun will shine again. All right. Professor Masiga is asking, what are some of the oral manifestations of COVID-19? Have either of the panelists had an opportunity to carry out oral examination on the patients at Mbagathi Hospital? I am not sure, Professor Masiga, about that. I don't think we've had to do a dental consult, but I'm up for correction if that has happened, but I don't think we've done any dental consultations from Mbagathi, KNH Mbagathi. Okay.
Oh, you're on. Oh, okay. All right. His internet is back.
Hello, Dr. Odhiambo.
Excellence, University of Nairobi, but unfortunately, it is letting me down more than probably should have been in the house.
It happens.
Okay.
Yes, Karibu.
The question that you had asked, let me just answer it. And I said that one thing is that dental practice as it are already, for those who are already observing standard infection control procedures, there's a very little to change. However, the main concern is now the aerosol generating procedures, which I think, and the fact that this disease now is already kind of in the community spread. And so that means every dental practitioner assumes that every patient we see is COVID positive. And we put in place procedures that can help. One of the key things I think is that all of us must now invest in disposable gowns. I would say that every patient should have possible disposable gowns, and we should have well-fitting N95 masks for aerosol generating procedures. There's a debate on whether these masks are possibly reusable, but that will come, and later on the manufacturers probably will let us know. There is a bit of talking about use of vaporized hydrogen peroxide as a means of treating the masks if they are very expensive. Obviously, dentistry was already a very expensive procedure, and if these are to be loaded onto the patient, then we foresee some kind of a steep climb ahead. But I think we would really have to get the government involved in totally removing maybe duty and taxes on these equipments, because this might become our new normal.
There was a question, Dr. Odhiambo, on the second line PPE.
Yes.
For routine use in the clinic. I think somebody needed a clarification.
Yes. Okay. What the second line PPE? The first line actually meant that we were only worried about the droplets. And where we were only worried about the droplets, then we would use the surgical mask and probably the goggles on eye protection shield without necessarily having to use the N95 mask or FFP masks, which are much more fitting and airtight seals. So that is actually the third level was where we expect that when we are going to do aerosol generating procedures, but this is probably almost nearly the routine dentistry is aerosol generating procedures, because we are talking about scaling, we are talking about the normal fillings, we are talking about bonding things where you have to really dry the surface with the 3 airway syringe. So really the first level, probably the second level, the first level is almost like having only gloves, but the second level protection, which should probably be left for doing things like biopsy, because they are not aerosol generating procedures, doing things like impressions for prosthetics and impressions for orthodontics. Those ones may be non-aerosol generating procedures where, and probably extraction, where you could use the standard surgical masks and eye protection. But immediately we go to, the current thinking is that if we go to aerosol generating procedures, then we go to the third level of protection.
Okay, thank you so much for that input, Dr. Biambo and Dr. Koech. I'll probably ask the final question. Let me see, out of all this, let me see. There's somebody who's asking about risk assessment questions. How will we be sure that they're answered correctly? There's a question. Yes.
You see, you really often we put levels of control. The first level of control, like a normal practitioner in medicine, your first level of control is simply to take the history of the patient. You really have to trust the patient to tell you the truth about their history. Sometimes they don't tell you the truth. Like, I mean, the last patient, I showed the picture here. It is claimed that this patient was one warfarin, wherever he was initially the tooth was being removed. But the patient probably, we don't know. The patient probably, having been told elsewhere that the tooth will not be removed because you are on warfarin and you are in pain, decides not to tell you that they are on warfarin. So our first level line of defense is to assume that the patients are honest. And if they are not honest, our second line of defense in this case would be that when the patients arrive at our centers, we take their temperature, for example, we examine them, and we again take their history and try to see if they are honest or not honest. But ideally, as a clinician, we normally have no way other than to believe our patients. If they tell you that they are not diabetic and they are not hypertensive, if you do not take the blood sugar, if you do not take their blood pressure, you will go by their words.
That's true. That's very true. And the final last question from Dr. Boga, although this is a petty question, but let me just ask it. He's saying, considering the absence of dentists and ENT doctors in this time, shouldn't these cadres be classified as non-essential services?
Considering the absence in? During
this time.
Who said they are absent? Who said they are absent? From the pictures I showed you,
yes,
the many pictures I showed you, I mean, my last slide, we showed several cases. Would somebody say that those are not essential services at this point? I think this is a concept which we must do away with. To think that since there is a pandemic, it is the only essential service. There are many people who are going to die of diseases that could be, I mean, at simple, and in fact, it is a more important life to save. If you went to the triage and where we were facing things like in Italy, where you are forced to decide which life should you save and which one maybe is, lives are all the same, but some lives are more important than the other. We know that in a triad, if you went and found somebody who is bleeding and you can only clip a blood vessel and you save the life, it is better than somebody who might require you to go and do thoracotomy to look for the bleeding vessel in the heart. So I really don't think that anybody should think that the ENT and dental surgery now or maxillofacial surgery are not critical, because there are patients who are getting injured, and I showed the pictures there. You saw somebody had fatal bleeding. Several people had fractures and trauma. There are people with the neoplastic lesions which are in primary stages and could be resected and life saved. And we cannot say that because there is COVID, therefore, all these other conditions are not important.
That's true.
Yes.
Thank you so much for that response, Dr. Odhiambo. Dr. Koech, thank you so much. We are all essential services. Everybody is, even the boda guy who delivers food to your doorstep is now an essential service person, because you can't do without them. We can't do without each other. So thank you so much for that presentation. We'd like to thank the team for maxillofacial and dentistry. Asanteni sana, and I'm sure your members have heard loud and clear what is acceptable, what they need to have to be on the front line, although they're already on the front line, but their bare minimum level of PPE. And I hope they'll be able to follow up and get the adequate PPE as they work in their different places. Even those who are still opening their private practice, I hope you will have the correct PPE to be able to see your patient. Your safety comes first.
I want to thank them for the attention, and I want to apologize for the persistent going offline. It was almost like, it appeared like it was almost deliberate, because it started immediately. I completed my presentation, but it was not deliberate. And what I want to tell the dentists and maxillofacial surgeons is that there are three factors that are critical for this. One, protection of ourselves and our families. Two, protection of our patients, so that we do not act as the epicenter of the disease. And three, protection of the community. We must be part and parcel of protection of the community. But of course, there's understanding that we must know that private practitioners depend on their private practice to survive. And I think even as the disease and the pandemic is with us here, we all must put our heads together, think of ways and means in which we can reopen our practices, but with minimal risks to the three cadres of the people we interact with. So I really want to say that, even Dr. Koech and I, we are in a panel of specialists who are trying to work out ways and means of getting ourselves back in our operation with minimal risk to ourselves, to our families, to our patients, and to the community.
That's true. Thank you so
Great,
much.
great.
Dr. Koech, final words?
Yeah, thank you very much, Dr. Odhiambo. That's excellent. Now, my appeal to my colleagues is, let's now try to be more innovative. Let's come up with solutions like Dr. Odhiambo has just said. And, let's not sit somewhere and expect that guidelines will just come to you. Let's give suggestions if you come across anything that may be useful. Because you see, at the moment, we are denying patients the care that they are used to. We have to find a way of being innovative so that we can reduce this inconvenience that is being caused to patients. Thank you.
Thank you so much, Dr. Koech. Thank you so much, Dr. Odhiambo. We truly appreciate you finding time to come and talk to us and tell us more about how to go about this during this tough time. But I'm sure we'll get out of it very soon, or rather we'll adjust to the new normal and be able to do our practices and run our practices. And I agree with Dr. Koech and Dr. Odhiambo, we need to be innovative. So Judy Kose, your statement was valid. It's about time we thought different ways, all of us, not just the dentist, all of us, different ways of doing things, maybe embracing technology a bit more, being innovative. So this thing is going to change us and the way we do things. So thank you so much. Just a small reminder, tomorrow we have 2 sessions. One in the morning, sharing experiences with the facilities that are managing patients, suspected and confirmed cases of COVID-19. And in the afternoon, we'll have a session on testing by the team from laboratory. So thank you so much for attending this session. For your CPD points, Mr. Mwenda is working on them. Be patient with us, give us time, and we'll be able to send them to your email addresses. Thank you so much and have a good afternoon. Bye.
Good afternoon.